Nocturnal analysis or breathing is when the child urinates in the bedtime. After 5 years, you call it nocturnal enuresis. In fact, 10% of the children at 6 years they do it. At 10 years, its incidence is a bit less, 5% or so. At adolescence, it is around 1% or so. And in 70%, it is monosymptomatic. That means your child do not have any other underlying issues like CKD, renal tubular acidosis, diabetes insipidus, diabetes mellitus, and any other disorders. So it is primary when child had never been dry. When it is called secondary when child had been dry, now turned anorectic. They were now again turning the bed, waiting. So it has two genes. A little bit of genetic involvement is there. Androgen 1 in the chromosome 13 and androgen 2 in chromosome 12 is said to be implicated over here. And so there can be first degree relatives affected by the disease, maybe commonly in the fathers, more common in the boys than girls. It has association with the overactive bladder, constipation, and small bowel, sleep disorders like fragmented sleeps, and it has other rare anomalies like Kakut, ectopic ureter, and so forth. And I said the diabetes insipidus, urinary tract infection, your attention deficit hyperactive disorders, autistic spectrum disorders, and oppositional or defined depressive disorders, the mood disorders, they can remain associated with the nocturnal enuresis. Treatment is a restriction of fluid 2 to 4 hours before the bed. So the child should should finish eating your night meals or the 2 hours before sleep. 4 hours is nice so that she or he doesn't need to take water and volume voiding before the your bed and raising waking the child 1 to 2 times before in between the sleep. Pelvic floor exercise to have the better bladder capacity is an important maneuver. But when the child has passed 6 years, you have your this time to treat the child. You have time to treat the child, and alarm the is said to be the first line, but rejection of the alarm is quite high because it creates a big loud noise in the family, and also it is to be device placed in the inside the child's waist. So many do not like this device. Rather, they opt to take your desmopressin orally available in the market as mineral melt. Doses 120 to 360 microgram at bedtime. Incremental dose at 2 weekly interval where the disease is controlled. Most usually, commonly, you need to take 240 milligram microgram, daily. Apart from that, we have anticholinergic oxybutynin 5 milligram at bedtime, and second line drugs like tofranil imipramine preparation is also available. So go on giving the drug for 2 to 3 weeks. We start with the mineral melt or desmopressin preparation. Orally, sublingual is better. And then previously we used to use it in the intranasal, but their absorption was a bit faster and more symptomatic hyponatremia was reported, and there are some seizure and casualties, and then morbidity was there. So people started taking the oral sublingual melt, and they continued for 2 to 3 times, to 2 to 3 months. Good amount of time. Your child responds well, 60 to 70% response rate, and they do well. But they relapse a good amount of time. Relapse cases can be retreated in the same fashion, and in the course of time, as I said earlier, 15% annual reduction of the disease load. Thereby, the disease with treatment, the your and the core child grows, it disappears. Ultimately, outcome is most of the time happy, but for 20% cases may continue as an adult anorectic. Be sure that in those cases you are not missing underlying disease like CKD, other tubulopathy, polyuric states like diabetes insipidus, diabetes mellitus, renal tubular acidosis, and urinary tract infection, and obstructive uropathy.